Good evening, everyone. Am I audible? So we'll start our case presentation today. So it's a 11 years old female child had complaints of fever for 2 to 3 days, 3 days back, followed by child was having decreased activity and child is becoming drowsy since last 36 hours. So the later the child had convulsions with tonic posturing. So the child was brought to ER. So our initial impression, according to the assessment triangle, appearance-wise, child is actively seizing, color pair peripheries, breathing-wise, increased work of breathing, and stridor present. So, what is the physiological status? So it's unstable, life-threatening condition. You have to start on oxygen mask with 5 liters per minute. Definitely, you need to put the child on lateral position, clear the secretions, and you need to ask for IV cannulation and move on to the next step. So your primary assessment, airway-wise, child is maintainable with suctioning and positioning. Breathing-wise, child is having rate of 30, bilate identity present, stridor is there, retractions, SALS 98%. So with conversions, we have started on O2. With O2 of 5 liters, child was saturating 98%. Circulation-wise, the heart rate was 160, pulses were normal, peripheries were cold. CRT is 3 seconds, blood pressure is 120 by 80. Disability-wise, child was actively seizing. GRBS is 180.
Hello, sir.
Hello.
A slide's not moving, sir.
Okay. Now?
No, sir.
Slides moving now?
No, sir.
No, sir.
Okay. Now is it moving?
No, sir.
Just give me 1 second. Is it moving now?
No, sir.
Not
Now also
moving.
it's
One second, I'll just close this meeting and restart it again. Please re-log in. Okay. Now is it moving?
Yeah,
Move అవుతుందా? Move అవుతుందంట. Okay. Thank you, Priya. So we'll start again. So it's a 11 years old female child with complaints of fever for 2 to 3 days. 3 days back, followed by decreased activity, and child is becoming drowsy since last 36 hours. So later, child had convulsions with tonic posturing. So the child was brought to ER. So our initial impression was, according to the pediatric assessment triangle, appearance-wise, the child is actively seizing. Breathing-wise, increased work of breathing, stridor present. Color-wise, child was having peripheral, pale peripheries. So what is the physiological status? So it is unstable, life-threatening condition. What intervention needs to be done? Definitely, we need to start the child on O2 with 5 liters per minute. You need to put the child on lateral position to prevent the aspiration. You need to clear oral secretions and ask for IV cannulation and go to the next step. So the next step is primary assessment, A, B, C, D, E. Airway-wise, the child was maintaining with suctioning and positioning. Respiratory-wise, definitely the child is tachypneic. With O2, child was saturating 98% with 5 liters of O2. Circulation-wise, because of the seizing, the child was having tachycardic, pulses are normal, but peripheries are cold, CRT 3 seconds, blood pressure is slightly higher side. Disability, GTCS, the child is actively conversing, and the GRBS we checked it is 180. So definitely the child is in respiratory distress, and because as said, there is no other this thing actively seizing, you're suspecting it could be primary cerebral dysfunction. So we need to start IV lorazepam. As the child is having febrile, you need to give IV paracetamol and antibiotic. So what is the definition of status epilepticus? So this I think we have discussed many times. I'll just give a brief this thing. So status epilepticus is a condition resulting either from failure of the mechanisms responsible for seizure termination or from the initiation of mechanisms which led to abnormally prolonged seizures. So as we know, the time limit T1 and T2 that I'm not going to discuss here in this particular this thing. So child was given IV lorazepam for 2 doses followed by a loading dose of lamivudine and phosphentine. So child seizures were not controlled despite first and second choices of AED. So we have decided to start midazolam infusion. So now I am telling it as refractory status epilepticus. So do you agree? Anyone wants to differ on that particular treatment? I have given a lamivudine and phosphentine loading dose, and straight away I went for midazolam infusion. Is it correct decision? So according to that, what is refractory status epilepticus? So refractory status epilepticus is nothing but status epilepticus persisting despite administration of at least 2 appropriately selected and dosed parenteral medications, including one benzodiazepine such as lorazepam or midazolam. So there is no specific seizure duration for this. You need to give 2 properly selected IV drugs, and out of that, 1 medication should be a benzodiazepine. Then you can term it as refractory status epilepticus. So this is the suggested algorithm for refractory status epilepticus. So our child is currently convulsing, right? So I have started rapid initiation of anesthetic AED. So I have given 1 dose of midazolam. The child did not respond. I have given Levipil and phosphentine. So child is fitting into the criteria for refractory status epilepticus. As I suggested and told, there is no time limit for refractory status epilepticus. So in this particular child, the decision is correct. We have cited straight away rapid initiation of anesthetic AED. Anesthetic AED is nothing but thiopentone, ketamine, or midazolam. So other slide, if a child is having, sometimes EEG might be showing non-convulsive status epilepticus or child might be in coma, you can try 1 or 2 non-anesthetic AEDs, such as you can try whatever the other drugs remaining, valproate or phenobarbital. If child still not able to stop that, then you can try initiation of anesthetic AED. If the child is completely non-convulsive or slightly conscious or partially consciousness, you can try 1 or 2 non-anesthetic AEDs, and you can try for IV phenobarbital loading. Then you can go for anesthetic AED. This is the protocol. So simple to make it simplified. Basically, your refractory status epilepticus is nothing but you have given 1 lorazepam, not controlled. You have given any Levipil. Nowadays, the drug of choice for all convulsions, the loading dose should be given with Levipil. So followed by Levipil, still seizures not controlled. I have given 1 dose of phosphentine, not controlled. The child is actually convulsing. So the next, right away, you need to move on to anesthetic AED, such as midas or this thing. Is it clear to all? Any doubts? Okay, so we'll go to the next this thing. So this child was given definitely 3% NS, because I just want to make a point here. Once a child is actively seizing in front of you, so it's like a injury to trauma to the brain, right? So it's like direct insult you are giving. That insult might be because of hypoxia, because of the convulsion, or whatever be the mechanism. So that will cause some cerebral edema. Then that too, our child is at status epilepticus, then went into refractory status epilepticus. We have started anesthetic AED. So definitely to prevent that, you can give 1 loading dose of 3% NS, and child, as a child is in refractory status epilepticus, and we have started anesthetic AED. We have decided to intubate this particular child. So intubation procedure was uneventful. Further course in the ER, child continued to have convulsive status epilepticus. So rapidly went up to midazolam to 10 mg per kg per minute. Now seizures are controlled. So CT brain was done, which was normal, and child was shifted to PICU. So what could be your DDs here? So what do you think the child had currently with this particular this thing? Anyone wants to add?
It can be infection, sir, or a seizure disorder.
Okay. Any other DDs? So definitely, yes, we need to rule out infections in this particular child. As such, the child had fever for 2 to 3 days, 3 days back, and followed by gradually dropping sensorium and decreased activity, and followed by the child was in almost completely convulsing state. So any other DDs in mind other than infections? So just to make it simplify, what are the causes of refractory status epilepticus? So this is divided into acute symptomatic, remote symptomatic, progressive encephalopathy, febrile, or any defined electrochemical syndromes, or cryptogenic. So acute symptomatic, such definitely yes in this particular child during acute illness involving in neurological insult, it can be meningoencephalitis or any metabolic dysfunction such as hypoglycemia or hyponatremia or even ALM. So remote symptomatic is nothing but status epilepticus in a patient with a known history of neurological insult associated with increased risk of seizures such as any TBA, stroke or static encephalopathy. As we all know, if they have any neurodegenerative disorders or neurocutaneous syndrome such as tuberous sclerosis, such something like that, in such cases also you can term it as progressive encephalopathy. So in our particular child, progressive encephalopathy is ruled out. Remote symptomatic is ruled out because there is no history of neurological insult. It can be acute symptomatic where the child can be having meningoencephalitis, definitely yes, and febrile, yes, or it can be any electrochemical syndromes, or it can be still cryptogenic, which is idiopathic. So with the clinical examination history and our findings, as suggested, meningitis, meningoencephalitis, seizure syndromes, new onset refractory status epilepticus, or cryptogenic. So investigations in a child with status epilepticus, simple investigations, any child without history of seizures, simple first line investigation should be very simple. Ionic or total calcium, especially less than 2 years. Check for RBS or sodium, and if febrile, you need to do CBC, CRP, and lumbar puncture. Second line, you have to go for MRI and EEG. So status epilepticus in any known epilepsy, first line you need to check for AED levels. So there are indications where sometimes you can check the valproate and phenytoin levels also. So you can know whether how is the drug this thing. And if febrile, definitely CBP, CRP, and LP. And if second line, you can go for RBS electrolytes. And if clinical suspicion of toxins, you can go for urine toxicology. So this child was shifted to PICU, start on 3% NS infusion and given dose of ceftriaxone and vancomycin in ER. And child was continued on mechanical ventilation. Child continued on strict neuroprotective care. We have given head and elevation, strict sedation, everything 3% NS to maintain euvolemia. We have even to maintain cerebral perfusion pressure. We have started some low dose norepinephrine. All the measures have been taken. We have planned to do continuous EEG to look for any non-convulsive status epilepticus. And we can't do LP in this particular child as the child is very unstable currently. So we have continued the maintenance dose of 2 AEDs such as Levipil and phosphentone, which we have loaded initially. And I'm continuing midazolam infusion with 10 mics per kg per minute. So EEG has been done. Now it is showing non-convulsive status epilepticus. As we have discussed, any child with refractory status epilepticus, if the child is having convulsions, initiation of anesthetic AED. So we went for midas in this particular child. Now child is having even non-convulsive status. As I told you, you can try another trial of non-anesthetic AED such as valproate. So we are loaded with valproate and increased midas infusion. So here I want to make a point here. When we want to increase midas infusion, simply you can't just keep on increasing the infusion. You need to give one loading dose of 0.05 to 0.1 mg per kg. Then only you can increase the midas infusion as per the protocol. So still non-convulsive status epilepticus was persistent, and in between the child had convulsions as well. So as accordingly as we discussed, according to the management of refractory status epilepticus, child is having convulsions along with non-convulsions also. So we have tried everything. We have tried as per the protocol of initiation of anesthetic. Then we are given trial of 1 or 2 non-anesthetic, still child in convulsions. Then I went to another anesthetic drug. So anesthetic AED, now I have started the child on thiopentone infusion after loading dose was given. So seizures were controlled after thiopentone infusion of 5 mg per kg per hour. Next 12 hours, no further seizures. So EEG also achieved burst suppression. So after 24 hours, we did LP. Total count was normal. Everything was normal. Meningoencephalitis panel was sent negative. We have done MRI brain, which was normal. So what are your DDs and how you are going to approach this particular child? Anyone? Now that we have suspected infection, the basic thing we have worked out, which is completely normal. So what could be your next workup? Because we need to think the child is actively seizing in front of you. We are already on maximum doses of 3 anti-epileptics and 2 anesthetic AEDs we have started for this particular child. So what could be your next DDs? Anyone? Anyone can opine here what you're going to do next. Definitely, it can be cryptogenic, as we already discussed. As I told you, acute symptomatic, remote symptomatic, static encephalopathy, febrile, and any syndromes or cryptogenic. So as such, we have ruled out acute symptomatic. Definitely, it is not a neurodegenerative case. So static encephalopathy is ruled out. Then other option is febrile. It can be. So the other is metabolic and currently toxins. So in that, how we are going to approach to the next step. So what is this NORSE? So you might have seen multiple cases like this in your PG days. Whenever you have seen any child with refractive status epilepticus, you might be wondering what to do next. So it is basically defined as a clinical presentation of new onset of refractive status epilepticus. It is nothing but in a patient without active epilepsy or any pre-existing relevant neurological disorders like any brain masses, acute strokes, and without any clear acute or active structural, toxic or metabolic. So you have to rule out everything. So we did MRI, definitely we have ruled out any active structural causes, right? And any stroke we have ruled out. We have did CT, that is also normal. So previously the child was not having any issues. And currently we are stuck up with either toxins or NORSE. So toxins we can't think and metabolic we can't think because it's 11 years old, developmentally completely normal child. So I don't think any IM will be presenting at 11 years of age, that too with any previous history completely being normal. So for my side, currently I'm thinking of new onset refractive status epilepticus, which will include fires and autoimmune encephalitis. Any doubts here?
No, sir.
Is it clear what did I said till date, till now?
Yes, sir.
So what is fires? Fires is nothing. This is also a new kid in the block. It is basically febrile infection related epilepsy syndrome, which is defined as a subset of NORSE. Basically, it is associated with prior febrile infection with fever starting between 2 weeks to 24 hours before the onset of refractive status epilepticus. In contrast, patients with new onset refractive status epilepticus may or may not be associated with fever. In our particular child, the child had fever, but definitely child may or may not be associated with fever before the start of fever refractive status epilepticus. So how we are going to rule out? So in this particular child, I'm thinking of currently autoimmune encephalitis. So what could be the major presenting features? There is a criteria for that. Simply you can't tell the suspicion. So we'll go to that slide next, but I'll just briefly give a description. So our child is having, what are the major presenting features? Seizure is there and behavioral changes is there. I mean psychosis. So child is having gradual drop in the sensorium, behaving abnormally. Minor presenting features, definitely decreased level of consciousness is there, and focal neurological deficit or speech changes are there. So potential signs of neuroinflammation, MRI, which is normal, abnormal EEG, yes. So our child is currently fitting into moderate clinical suspicion. 2 of 3 major features are present. One is seizure, the other is behavioral change, and minor features are there. So we'll go to the next step. I'll come back to that one. I'll come back to this slide. So we started weaning after 24 hours as there are no further seizures as per the protocol. So child developed seizure once weaning has been started. So what should I do now? So I have followed the protocol correctly. I have did everything correctly. I did LP, I did MRI, I did EEG. Everything is ruled out. Now I'm thinking it could be new onset refractive status epilepticus. Currently I'm thinking it could be autoimmune. So okay, I thought first I will wean this thing, but I have started weaning and there are no further seizures. But once the weaning has been started, child developed a seizure. So what now? It's the child is fitting into super refractive status epilepticus. So what is that term meant? Any status epilepticus that continues 24 hours or more after the onset of anesthesia, including those cases in which the status epilepticus recurs on reduction or withdrawal of anesthesia. So definitely we have started anesthesia, and now the status epilepticus recurs with the reduction or withdrawal of anesthesia. So what are the options in super-refractory status epilepticus? Ketogenic diet, pyridoxine, immunomodulation, inhaled anesthetics, and epilepsy surgery consultation. So now the child is on maximum doses of Levipil, phosphentine, valproate, and we even discussed with the pediatric neurologist in this particular child, and he told to start lacosamide and phenobarbital. The child continued to be on strict neuroprotective measures. So now in clinical dilemma, now with multiple AEDs and also anesthetic drug infusion, what could be the next step? So now we have the suspicion of autoimmune or query fires. So we have started the immunomodulation therapy, and workup for autoimmune panel has been sent. So let's go back to the previous thing. As I have discussed here, the child is having fitting into two of three major features are present, and minor features are also there. We have moderate clinical suspicion. We have did MRI, which was normal. EEG was done, which is abnormal. CSF analysis, we need to send for autoimmune antibodies. So whenever you are suspected autoimmune encephalitis, it is a very rare term. People will be very reluctant to have this diagnosis of autoimmune encephalitis. Why? Because whenever you are thinking of refractory status epilepticus, as we have discussed again, I am repeatedly telling, it could be acute symptomatic, remote symptomatic, febrile, toxins, metabolic, or cryptogenic. It can't be anything else. So out of that, we have worked up step by step, doing LP, then we did EEG, infectious part is ruled out, even we assigned meningoencephalitis panel. The causative organism was negative. So what is the proposed classification? So simple. Comes to anatomical classification, you can see 9 types are there: limbic, cortical, striatal, diencephalic, brainstem, cerebellar. Serological classification, usually we'll do common antibody testing such as voltage gated potassium channel, VJKC, or it could be any NMDA, excitatory neurotransmitter, or GABA receptor antibodies, or it can be MOG or aquaporin. So these antibodies you can send from the CSF analysis. As you are seeing here, sometimes you might be wondering, so I have did everything correctly, sir. I have started anesthetic drug, as you told, I have ruled out your infectious causes. Now it is not fitting into anything. Even remote symptomatic can't be, and static encephalopathy, no, child is completely normal. No previous neuro insult is there. Even I was told, as per your diagnosis, I suspected new onset refractory status epilepticus. In that you told it could be fires or autoimmune. So now I have thought autoimmune, and I have sent my antibody panel. So that also turned out to be negative. So what I'm going to do next? So one thing you need to remember, there is a term called as seronegative autoimmune encephalitis. But one thing you should be clear in your mindset is you need to rule out all other particular causes before you come to this diagnosis. And going into the criteria, you should look to clinical suspicion should be there of autoimmune encephalitis. And etiological classification for autoimmune encephalitis, it could be idiopathic, it could be paraneoplastic, it could be post-infectious, or it could be in iatrogenic also, in the setting of if you're giving any immunomodulating agents for this particular child for any like steroid resistant nephrotic syndrome or something like that. So these 4 things you need to keep in mind. One thing, as I suggested, it could be multiple areas are involved, and it can be seronegative autoimmune encephalitis. But before that, you need to make sure you have to send all the antibodies. Sometimes your glycine receptor or aquaporin, which can't be done clinically, it will take some days to get the report. So before that, you can try this concept of seronegative autoimmune encephalitis. So as we have discussed in this particular child, anatomical classification, as such, the child is having epilepsy is there and cognitive issues are there, right? So it could be cortical or subcortical encephalitis classification of autoimmune encephalitis. Corresponding cognitive presentation is there because the child is becoming drowsy, decreased activity, and excessive sleepiness along with seizure presentation. Or it could be even limbic encephalitis, or it could be meningoencephalitis part of autoimmune encephalitis, where your child was having cognitive seizure presentation and meningeal presentation. Sometimes, as you see here, meningoencephalitis autoimmune, your seronegative autoimmune can be a huge possibility. So now that the child is it clear for everyone until now what I have told, or should I repeat it? Should I repeat it, or is it clear? So shall I move on, or?
So you can move on, sir.
So now it is fitting into super refractory status epilepticus. So as I suggested, these are the options. So now the child is in everything. So what should I do? We have the suspicion of autoimmune. And I have told we have sent the CSF autoimmune workup for aquaporin antibody, MOG antibodies, and NMDR and voltage gated potassium channel. So we have started the immunomodulation therapy and workup has been sent. So CSF analysis, which has been sent, and we have started the child on IVAG 2 gram per kg, and you have started on IV methylprednisolone 30 mg per kg. Gradually, the seizures were controlled. We were able to wean the thiopentone and stopped. Child was extubated 48 hours later onto oxygen face mask. Gradually, O2 was weaned and stopped. The child was discharged on oral levipil, phenytoin, and lacosamide. So how you are going to approach this particular child with just given a protocol management for refractory and super refractory status epilepticus? You need to start with IV Medas infusion. As I suggested, you can increase by giving 0.1 to 0.2 mg per kg. One start dose, then you can increase slowly. So you can go maximum to 20 mics per kg per minute. Some people take 26 mics per kg per minute. You need to start EEG monitoring, ET intubation if not already done. So therapeutic target not achieved. So no burst suppression. You can start IV ketamine or pentobarbital or thiopentone. So still your therapeutic target not achieved, you can consider other therapies such as immunomodulation and pyridoxine or ketogenic diet. So how you are going to achieve the target? Complete suppression of seizures, EEG burst suppression around 70%. You need to maintain the suppression at least for 24 hours. So that's what we did. Once weaning has been started, the child throwing convulsions. So after that, we have given time for more than 48 hours duration, slow weaning. Decrease rate by 20% every 6 to 12 hours. If you are fastly weaning, less than 48 hours, you can wean by every 2 hours. So we can finish off the weaning in 12 hours. But our particular child repeatedly was having, so we weaned over slowly over 12 hours, 6 to 12 hours. So you need to add maintenance at anti-seizure medications. You need to give doses at high end. So this is the reason we have considered this diagnosis of autoimmune encephalitis for this child. It can be meningoencephalitis. One thing I want to make clear in this particular presentation is that you need to think of other steps of management. So simply when you reach the dead end, you can't just wait and think what could it be. You need to have on your mind this nucleus in the block, which is new onset refractory status epilepticus, which can be fitting into either FIRES or autoimmune encephalitis. So workup you need to send. You need to start IVIG and methylprednisolone. Okay, thank you everyone. I'll conclude this meeting.